Thank you, everyone. Good morning. It's very happy to present here and happy Friday. So first of all, I have no financial disclosure or conflicts of interest to describe here. So in 2013, the USPSTF, the U.S. Preventive Service Task Force, make the first ever recommendation for lung cancer screening. The screening criteria is screening between age 55 to 80, more than 30 PAC years, and for former smoker who quit in the last 15 years. And in 2021, the task force lowered the starting age from 55 to 50. They also lowered the PAC year from 30 to 20. So today I'm going to tell you the story of my involvement with the task force recommendations and how they came about. So lung cancer screening, people were interested in lung cancer screening for a very long time. One of the earliest studies is the LCAP 1 and 2 study that found more than 80% of people given a diagnosis of lung cancer due to annual CT screening had a clinical stage 1 cancer. And a follow-up study, the international LCAP study, found survival rate of people with the stage 1 diagnosis has a 5-year survival close to 92%. And these studies together, they show CT screening can detect curable cancer. But one of the LCAP study are not randomized, so they have no control arm. So after the LCAP study, many small studies came out about that show various benefits of lung cancer screening. And the big trial that came out is the NST that came out in 2011. The study result was published in New England Journal of Medicine. The NST compared lung cancer screening with low-dose CT versus chest X-ray. The enrollment criteria is between 55 to 74. Remember, this is the enrollment criteria. There's a time that you start to enroll these people, these patients into the trial. Even though people always cite 74 as the start age of the NSC, but in fact, many people receive CT screening until age 77. The NST found a relative lung cancer mortality reduction of 20%. This is the first time that is a very big trial that showed definitive benefit of lung cancer screening using low-dose CT, but the comparative arm is chest X-ray. In the same year, the PLCO published the result. The PLCO compared chest X-ray with no screening, and they found there's no statistically difference between the lung cancer mortality reduction between the two arms. So you have two trials, one NST that compare CT with chest X-ray, and then you have another trial that compare chest X-ray with no screening. So in 2011, the task force wanted to estimate the impact of lung cancer screening in the US. We have result, at that time, we still didn't have any LCT that directly compare chest X-ray with no screening, which is the practice of usual care of lung cancer screening at that time. And they also want to know the mortality reduction when screening is implemented in the United States for the general population. remember the 20% mortality reduction observed in the NSC is the mortality reduction among people who got screened. So you have a lot of people who do not have the benefit of screening. That will dilute the mortality reduction if you implement it in the whole US, because some people just never got screened and they will still die from lung cancer. And there are other outcomes that the task force were interested. For example, the radiation-induced cancer, how many radiation-induced cancer you will generate if you implement it in the US resource utilizations. At that time, the task force for that simulation modeling could help to combine and extrapolate the results of NSC, PLCO, and other studies to lung cancer screening with various screening eligibility criteria and screening populations, screening frequency in the US population. As Dr. De Host mentioned, that I'm part of CISNET. The task force identified CISNET as the group to help them to make the decisions. CISNET stands for Cancer Intervention and Surveillance Modeling Network. We are a consortium of NCI-sponsored investigators who use simulation modeling to improve our understanding of cancer control. Between 2000 and 2009, 6 CISNET groups were established. And in 2021, we added 4 more CISNET cancer groups. Altogether, we have 10 of them. 4 of these CISNET cancer groups, breast, cervical, colon, and lung, have helped the task force to develop guideline recommendations. The crown jewel of the CISNET lung pathway is the smoking history generator. This smoking history generator is owned by the CISNET lung. The CISNET lung group has 7 individual research groups from different medical center, hospital, and university, but this is owned by the whole group. So the smoking history generator is a software package that we developed that use multiple data sources, including NHIS, CPS 1 and 2, Berkeley Life Table, package it together, and it can simulate individual smoking history of the US population for people born between 1900 to now. So the public versions of it cannot do extrapolations, but the version that we have internally can actually do extrapolation to beyond 2024. And I want to mention that this is we have a version that's publicly available for researchers, and CDC and FDA have used it to help some of their analysis. In fact, Rochelle Walensky, our previous CDC director, when she was at MGH, I actually helped her to adapt the smoking history generator to study the lung cancer mortality associated with smoking and smoking cessation among people living with HIV in the US. The model that I use is called MELCAN, Multiracial and Ethnic Lung Cancer Model. This is what we call a simulation model in the jargon of our modeler. Micro-simulation is like micromanaging your simulated individual. In the model, it generates the life history of individual patients and aggregated to output the population statistic, and the input of the smoking history is provided by the smoking history generator. The model simulates underlying disease progression and clinical events, and we use the model to conduct in silico trials. So a previous model has been used in multiple studies. The CISNET group has a certain standard for all the participants. Everyone, the model has to calibrate to a set of common calibration target. For example, we all have to calibrate and validate to the observed US lung cancer mortality. We have like 2 papers that show our work of our calibration, and we also extrapolate and estimate that the lung cancer mortality will decline due to the fact that like we have fewer and fewer smokers in the US. So now come to the first US preventive service recommendations. That I'm tell you some of the history of like how we prepare ourselves for the first US how we prepare our decision analysis for the first task force recommendation for lung cancer screening. In addition to the lung cancer mortality in the US, for the task force recommendation, we also got a first dip of the NSC and PLCO data to use in our study. We use it to calibrate our model and fit our model to the NSC and PLCO data. For the decision analysis, we use a 5 model, and we all simulate different screening scenarios. We vary the ASAP screening, pack year, screening frequency, year script. All together, we model more than 1,000 screening scenario. Combination of all these things, all these variables all together came out to be very, very big. We conduct the in silico trial on computer. If you want to conduct RCT in real life using real people, simulating so many arms is just not possible. Financially, you may not even have enough people in the US to conduct a trial this big. So after we simulated all the different screening scenarios, we average the result between 5 different groups, and we plot them on the graph. The 2 key health outcomes that the task force were interested. One is the lung cancer mortality reduction. The second one is the number of CT scans per 100,000 people. There are other health outcomes that the task force were interested, but these 2 are the two health outcomes. Most important health outcome. These 2 health outcomes actually are conflicting because you want to maximize the lung cancer mortality reduction, but at the same time, you want to have as few CT screens as possible because that costs money. And we plot the results on the graph, and then we remove the scenario that's below this outer envelope of the health outcome. These 2 are what we call dominated strategies. And after we remove the dominated strategies, this curve here is what we call efficient frontier. It's just a jargon, but basically it says these scenarios are equally good. You cannot have, if you fix the number of CT scans that you want to have for the general population, you cannot have any better mortality outcome than the number on this curve, because we will remove everything below. You cannot have anything above this curve. And these scenarios are all equally good, depending on how many CT screen you want to have for the whole populations. And we presented the result to the task force. And then at the end, they decide to pick the annual screening between age 50 to 80, 30 per year, and ESIN squid 15 as the final decision, which is very close to the NSC criteria. NSC criteria, people have the same screening start year, per year, and ESIN squid, except the stopping age is a little bit older for the in the recommendations. And then the task force make the recommendation at the end of the 2013, at the last day of 2013. Because when we did the decision analysis, the task force were not interested in looking at costs. In fact, like all of the US preventive surveys recommendation, they did not consider costs in their decisions. Independently, after we helped the task force, we conduct a study to look at the cost effectiveness of lung cancer screening in the US, and we determined that the task force recommendation is in fact cost effective. The incremental cost effectiveness ratio, ICER, is less than 100,000 per quality adjusted life year, which is a commonly used threshold. It's closer with 96,000, close to 96,000, but it's cost effective if you use the 100,000 threshold. So after the first recommendation, many things happens in two fronts, in the clinical development, and then there's something called risk model-based screening that I will tell you after the clinical development. In terms of clinical development, people observed that the lung cancer screening uptake was very slow. Using the 2017 birther surveys, our colleague here at Mount Sinai, Minal Kelly, observed that in 2017, the lung cancer screening uptake is only 16.3%. Just to give you some contrast, breast cancer screening is about like 80% uptake. Colorectal cancer screening is often cited as between like 60 to 70% uptake. So 16.3 uptake is very, very low. There are also some studies that show the task force recommendation generated some racial disparity. Using the Southern Community cohort, a group observed that among people who get diagnosed with lung cancer, African American tend to have lower per year. So the figure on your left, the orange bars represent the African American. The light gray bar represent the counterpart, for white patients. African American, when they get diagnosed with lung cancer, they tend to have lower PAC years compared to white. The figure on the right-hand side, this one is basically just the cumulative function of the frequency on the figure on the left. So basically tell you the same information. So because we were using 30 per year, so we, in the task force recommendation, African American tend to be excluded from the screening trial. More of them get excluded from the screening criteria compared to white. At the same time, some study came out using the Chicago race eligibility for screening cohort. This study showed that the task force criteria is less sensitive in terms of picking female subjects for screening. The criteria are less likely to pick up people, female who potentially have lung cancer for screening compared to male subjects. So these two papers together show that the task force recommendation, the old task force, the first recommendation, so both racial, ethnic disparity and gender disparity. Another big development in the screening world is the Nelson trial came out. The Dutch-Belgium lung cancer screening trial came out. This is a big trial that first time showed the benefit comparing CT screening with no screening, and they observed a 24% mortality reduction, which is even better than the NSC result. So at the other front, many people were interested in risk model-based screening. Let me first define some of the terminology first. Risk model-based screening sometimes is referred as risk-based screening. This type of screening strategies uses a risk prediction model to determine screening eligibility. Risk prediction models are basically probability equations of lung cancer risk. It can be lung cancer incidence or mortality with inputs such as patient's age, sex, gender, and other variables. Patient will undergo screening if the estimated probability of lung cancer is larger than some threshold. In contrast, the risk factor-based screening use the traditional starting age, stopping age, pack year, and incidence quit. The task force recommendation are the example of our risk factor-based screening. There are like some trial after the first recommendation, that first task force lung cancer screening recommendation that came out that show potential benefit of risk-based screening, including the PanCan study that's conducted in Canada, the UK lung cancer screening study that also shows some potential benefit of using risk model-based screening strategies. Today, I'm going to select 3 models to show you. These 3 models are risk prediction model that the CISNET has identified to be more promising risk prediction model in the literature. In fact, there are many models in the literature published. Like in one of the studies that we conducted, we evaluated 7 of them. But today I'm only going to pick out like 3 of them to show you, to describe to you how they perform. The first one is the BART model. This one is probably the simplest compared to the next 2 that I will describe to you. The model was developed in 2006. It predicts the annual absolute risk of being diagnosed with lung cancer. The risk is based on age, sex, asbestos exposure history, and smoking history. A validation study found that the BART model performed very well for the first 5 years of observations, and then afterward, the model slightly underestimated the observed lung cancer risk in the cohort, in the data set that the validation study used. The second model, which is probably like more well-known, currently more well-known and more people use, is the PLCOM 2012 model. The developed by Martin Temimagi at Broad University. I have to point out that like Martin actually developed like several versions of this model after the 2013 New England Journal paper. I think he has like 3 or 4 of them, 3 or 4 versions of the model, but the commonly used and commonly cited model is a 2012 and 2000 PLCO and 2012 model. From now on, I'll just refer this as a PLCO model. The PLCO model predicts the incidence of lung cancer within 6 years of screening using 11 predictors, including age, race, sex, education, BMI, history of COPD, personal history of cancer, family history of cancer, and smoking status and intensity. This model, in a validation study, it will perform very, very well. And the last model that I want to describe, want to tell you is the lung cancer death risk assessment tool. The abbreviation of the model is called LCD-RAT. This is a prime example that when you make an acronym for the project that you're working on, be very careful checking with other people first, because sometimes we refer this as LCD-RAT model, which is not very flattering. So the LCD-RAT model predicts the probability of lung cancer death within 5 years. The model is actually very similar to the PLCO model, except instead of predicting the lung cancer incidence, you predict the lung cancer death. Instead of 6 years of incidence, it's 5 years of death. Hamukaki, in fact, was the second author of Martin's paper, the PLCO model. There's a lot of similarity between the two models. They use very similar covariate in the risk prediction model, but the difference is it predicts death instead of incidence. And this model in a validation study, it showed that it prevented, using this model as a screening criteria, it prevented more lung cancer death and number needed to screen than the US Preventive Service Task Force recommendations. So in around 2020, at the end of 2019, the task force decided to make investigate lung cancer, revisit their first original recommendations. So they, due to the new development in lung cancer screening, they recommissioned a simulation study to estimate the long-term harm and benefit of lung cancer screening. We also helped them to develop the guideline. So the study method is similar to the method that we used in the 2013 decision analysis, and instead of 5 models, we use only 4 models because one group were not included in the grant review. The difference is this time we use both risk factor-based and risk model-based screening strategies. The risk model-based screening strategies were not included in the 2013 because all the risk prediction model came after the 2013 recommendation. Another difference is the main benefit measure of lung cancer screening is the lung cancer death averted and life year gain compared to no screening. The life year gain basically just increase in life expectancy average among the whole population. This health outcome measure was provided in the 2013 recommendation, but it's not used in the final decisions. That actually make a big difference in terms of the newest recommendations. So for the total screening scenarios, we examined multiple screening scenarios. We look at risk factor-based screening strategies. We look at about like 300 of them. And we look at actually more risk model-based screening strategy, almost close to 800 of them. So we presented the average among 4 models, the risk factor-based results across 4 models. We showed it to the task force. The figure on the left is the death averted per 100,000 population. The figure on the right is the life year gain. If you look at the newest recommendation, the 2021 recommendation, if you look at the cancer death averted, it's actually not on the frontier, but it is on the frontier if you look at the life year gain, because death averted and life year gain slightly measure the benefit of lung cancer screening differently. If the task force didn't look at the life year gain in this round of recommendation, they would not have picked the newest recommendation in the final decisions. So when we look at the first guideline and the second guideline, going from 2013 and 2021, when we look at the impact on racial disparity, going from the old one to the new one, in fact, all races have an increase of the percentage of people eligible for screening, but the relative increase a difference between different racial group. For non-Hispanic Black, it's a 105% increase going from the first recommendation to the second recommendation. For non-Hispanic White, it's only 78% increase in terms of the percentage of people who are eligible for screening. If we examine the old guideline and new guideline on the impact on gender, women have a higher increase of percentage eligible compared to men. Women is 96% increase, men is 81% increase. So the concept is rising tide raises all boats. So by lowering the ASAP screening and lowering the PAE criteria, everyone get an increase of percentage of eligible people, but women and minority tend to have a higher increase, relative increase comparing the old and new guideline. So when we evaluate the risk model-based screening, we look at the lung cancer death prevented and the life year gained. The red square here is the task force criteria. All the other curves are the risk model-based screening strategies. This is lung cancer mortality reductions, lung cancer death prevented, and life year gain. The risk model-based strategy prevent more lung cancer death than the task force recommendation, but they only use more additional life year gain. Why is it the case? Because the risk model-based strategies tend to increase the overdiagnosis, and they tend to predominantly select older individuals. Lung cancer risk is has a very sharp increase with age. So if you use risk as a selection criteria, it tends to select older people. So the task force decided not to include any risk model based in the recommendation. They came up with the recommendation almost 3 years ago, a little bit more than 3 years ago. So they decided to stick to the risk factor based recommendation, but just lower the ASAT screening and the PET year. So are we ready for risk model-based screening? It's known that like some people who are at risk of developing lung cancer do not meet the task force eligibility criteria. Risk model-based screening strategies present a strategy for risk stratification beyond using risk factors. It's supported by some study, but the limitation is overdiagnosis, and there are so many risk prediction models out there, it's hard to pick a winner. So currently, it may not be feasible. It may not be, we may not be ready now, but maybe in a few years, if we have more evidence on which model perform better and how to overcome the overdiagnosis weakness of risk model-based screening strategies. Maybe at that time, then we'll be ready for risk model-based screenings. So after lung cancers, the second recommendation, what happened now between 2021 and now? A paper that just came out recently, 3 days ago, that used Berger surveys, 2022 Berger study surveys that showed the lung cancer screening prevalence among eligible people is 19.6% using the 2013 criteria, and using the 2021 criteria is around 16.4%. So remember, like many slides ago, I showed the result using the same Berger study, but different study group. We observed 16.3 using the 2013 criteria and 2017 Berger survey. So it seems like there's an increase in the lung cancer screening uptake. There are other efforts trying to increase lung cancer screening uptake too. Last year, the American Cancer Society revised their recommendation for screening. The screening guideline, the screening recommendation in 2013, the ACS recommendation was between age 55 and 74, more than 30 per year, and former smoker who quit within the last 15 years. I think actually the ACS at that time, they make a mistake because they stuck with the enrollment criteria of the NST, stick with 55 to 74 without realizing some people in the NST trial actually got screened until age 77. I thought that was a mistake. But in the 2023, the newest recommendation, they pretty much follow the newest task force recommendation guideline, except they remove all the years since quit criteria. Any years since quit, if you are a former smoker, as long as you have 20 years, you are eligible for lung cancer screening. I think that was a very wise decision because the CISNET criteria causes a lot of confusion within the medical community. One of the very common questions I get asked by my physician colleagues is, if I have a patient who came for screening last year, who quit in the last 14 years, and now he quit 15 years ago or 16 years ago, should I still keep the person in the screening program or not? If you strictly follow the guideline, you should not screen that person, because lung cancer risk decreases as you when you start quitting smoking. The longer you quit, the lower your risk of getting lung cancer. So if the risk is below certain number, you should not screen that person. But that generated a lot of confusion. People were not very sure. They say, oh, this person is like get screened. Even for the patient, it's like, oh, how come I got screened last year, and this year I don't get screened? So it causes a lot of confusion. By removing the CISNET criteria, is actually make it a lot easier. But this is an opinion, so I want to emphasize that we should also screen patients, follow the task force recommendations. So now I want to tell you some of the emerging technologies in the lung cancer screening space. One of the more talk about screening technologies are blood-based biomarker for lung cancer screening. Blood-based biomarker is a non-invasive diagnosis that try to use bodily secretion to test for signature of cancer markers. Yes, people have been working on this for a very long time. The consortium sponsored by NCI is the EDRN that established, I think even before 2000, and they are still going on. And here I'm listing a list of biomarkers that I know of and their relative performance extracted from the literature. One of the more well-known biomarker tests is the Galway test by Grell. The Galway test is actually a multi-cancer early detection test that can detect multiple types of cancers without one single blood draw, but it can potentially be used for lung cancer screening. The technology uses cell-free DNA and using methylation to determine the cancer of origins. But if you look at the sensitivity of the Galway test, it's actually not very good for early stage lung cancer. But that is not my major. There is a concern here. The development of it, the performance is not good, but a bill was introduced to the House of Representatives called HR 1976. The bill asks the Medicare to cover multi-cancer early detection tests. Currently, the Affordable Care Act requires private insurance plan and Medicare plan and Medicare to cover preventive surveys that receive grade A and B recommendation for the from the US Preventive Service Task Force with no cost sharing. But if this bill gets passed, they can bypass the US Task Force recommendation. They don't need the US Task Force, USPSTF USPSTF recommendation to require private insurance and Medicare to cover the MCED test. A similar bill, is not as strong language as the previous one, require additional lung cancer screening tests under the Medicare program. So this is like this raise some concern within the research community. Like if these two bills get passed, and that can potentially generate a lot of problem for precision to the performance of our lung cancer screening. So another new development in lung cancer screening is the management of suspicious nodules. When the nodules get detected during lung cancer screening, there's a lot of variability between radiologists' interpretation of the CT scan. AI can potentially help to reduce the variability between the radiologists. A study showed that using AI, the reproducibility of the algorithm is actually very similar to the radiologists. I previously did a lot of review for the journal Radiology, which is the #1 journal within the radiology field, and we got a lot of papers. There are a lot of research, a lot of work has been done, and continue to be done to use AI to determine the categories of nodules, try to separate them into solid pastoral nodules, ground glass nodules, and try to determine the risk of these nodules of being cancer. So it may be that it's not ready yet, but I think it's coming out pretty soon. So in summary, I have discussed the first and second USPSTF lung cancer screening recommendations. I discussed the challenge of implementing the screening recommendation, including the racial disparity and the low uptake of screening. I also discussed the risk model-based screening and some of the newer technology, biomarker and AI nodules management algorithm. That concludes my presentation. Thank you.